Thank you so much for joining this webinar on Infusion Medicine 101. I am incredibly excited to launch into this discussion, and I know from the attendees and signups that we have a lot of interest, and so we're going to jump right in. My name is Darren Anderson. I am the president and founder of ConferMED. I'm the former director of the Weitzman Institute and the general internist. I have worked in the health center world since residency. I'm an alumnus of the National Health Service Corps, and it's been my privilege to work in primary care since 1998. And I will be moderating today's discussion and kicking things off. I'll be introducing our speakers, and we will be monitoring and fielding your questions as we work our way through the topic. So please, if you would use the Q&A button at the bottom of your Zoom screen to post any questions, we'll do our best to get to as many as we can during the live session, and any that we're not able to respond to in time, we will follow up after the session. So let's jump right in. If I could have the next slide. So in 2010, I was working in Connecticut, and I came across an article, and I learned about something new called Project ECHO. And what I learned was that there was a gastroenterologist named Dr. Sanjeev Arora, who was an expert in treating hepatitis C, and he worked at the University of New Mexico in Tucson, Arizona. And as I learned a little bit more about this, what I came to know was that he was the only specialist in the state of New Mexico who would treat Medicaid patients who had hepatitis C. And the result of that was that people came from all over the state of New Mexico to Tucson to get treatment for hepatitis C. And many of them arrived too late. Many of them struggled or weren't able to make the trip and the travel and such. And outcomes for hepatitis C were poor. At that time in 2010, the treatment of hep C was extremely complicated. It's still challenging, but it's gotten much less complicated over time. So he got the brilliant and deceptively simple idea that maybe he could set up a video conference with himself and a team of experts from the University of New Mexico, and they could join with primary care providers from the community health centers around the state. Those providers could present and discuss their cases, and he thought perhaps our team of experts can guide them through the evaluation, management, and treatment of these patients. And that came to be known as Project ECHO, extension for community health outcomes. And what I found most fascinating, you can go to the next slide, is in 2011, they published their results in the New England Journal of Medicine. And they basically concluded that primary care providers and community health centers achieved hepatitis C treatment outcomes equivalent to an academic medical center specialty clinic using the Project ECHO model. Since that time, Project ECHO has exploded and has expanded across the country and around the world, and primary care providers have learned how to use buprenorphine for treatment of substance use disorder. They've learned how to manage chronic pain, and a wide and growing range of complex chronic illnesses and other topics have been taken on by primary care providers and community health centers using the Project ECHO model, and essentially using technology to connect and communicate with specialists to bring care that otherwise would be unattainable to their patients. Next slide. And if you think about this in the historical context, this is what community health centers have been doing for more than 50 years, been tackling complex illnesses and providing treatments that the health system fails to deliver for the underserved. Next slide. So today we have a new topic, and we have new opportunities. We have new treatments in the area, in particular of infusion medicine. Infusion medicines are transforming medical care and having really a marked impact on a wide and growing range of illnesses and problems, particularly autoimmune disease. It's estimated that 50 million Americans have a form of autoimmune disease, and many of these illnesses can be treated more effectively than in the past using either infusion medicines or injectable medications. We're now even using infusion medications to impact complex migraines, various dermatologic problems, and even asthma, and many more. Next slide. The problems are many with these new meds. 40% of infusions occur in hospitals. If you live in a rural setting and don't happen to have a hospital nearby, that can be a barrier. And the cost of receiving infusion is two times more in a hospital than it is in a non-infusion site. Americans who have insurance but have high deductible health plans and copays often face out-of-pocket expenses that they're unable to make. And most infusion centers do not accept Medicaid. And for the uninsured, forget it. There really is, it's a very, very difficult to find a path to getting an infusion treatment that you need if you don't have insurance. Next slide. So to demonstrate that point, this is a map prepared by our colleagues at Junction Health, who are going to be speaking in a second, showing just a typical urban area. This is Boston. The blue dots represent infusion centers in the greater Boston area. If you go to the next slide, you'll see how many of those dots remain when you factor in which of them accept Medicaid. So if you are a patient with Medicaid insurance in the Boston area, one of the medical mecca regions of the country, infusion medications for some of the conditions that I mentioned are very likely out of reach or extremely difficult to access. So next slide. So what we're going to talk about is really just following in line with with the way I frame this up, Project ECHO, community health centers. We're going to tell the story today of how one community health center and others as well have tackled the topic of infusion medicines and are working to figure out how they can bring these life-changing medications, often life-saving medications, and provide them in the community health center setting. Because as the map that I just shared demonstrates, relying on the medical system outside of community health centers is probably not going to do the trick for our patients. And so just like we've done before, community health centers are going to step up and find ways to deliver these medications and to make these treatment available to the patients that we care about. So it's with great pleasure that I introduce our panel and get this session started. First, we have Dr. Ashley McPhee. Dr. McPhee is a pediatrician, and she's the Chief Medical Information Officer at Tampa Family Health Centers and the Chief Medical Officer. She's also been the clinical project lead for implementing and launching the infusion medicine program at Tampa Family Health. She went to Xavier in Louisiana for her undergraduate and got her medical degree at the University of Mississippi Medical Center in Jackson and completed a pediatric residency at the University of Florida. She's a fantastic speaker and a fierce advocate for our patients and has really been the driving force behind this project that we're going to talk about. She is then going to be followed by Vinny Polito, who is a PharmD and is the COO of Junction Health. Vinny is a really seasoned health system leader. He's been working in the field for over 20 years, both acute and ambulatory pharmacy, and he's a particular expert in 340B optimization and pharmacy strategy. He has been the lead at Junction Health in helping work with Tampa Family to implement their infusion center and get the project up and running. Following that, we have Dr. Christian Jackson, who is a board-certified gastroenterologist who's been practicing for over 19 years. I didn't realize this until I saw his bio. He did a full internal medicine residency and practiced in internal medicine before going back and completing a fellowship in GI. And has now been practicing gastroenterology in Southern California for several years. He is a clinical professor at the Department of Internal Medicine at the University of California, Riverside, and he is one of our ConferMED GI reviewers, and he is one of the reviewers providing e-consult support for the infusion medicine project at Tampa Family Health when infusions for ulcerative colitis and Crohn's disease are being contemplated. So these are the people that are going to briefly talk through their story and describe what they did, and we're going to pretty quickly move to questions. I have prepared some questions for them, and we'll be taking audience questions as well. So without further ado, I will pass the baton over to Dr. McPhee. Dr. McPhee, thank you so much for being here.
Thank you, Dr. Anderson, and for the wonderful introduction as well. As Dr. Anderson said, I am a pediatrician by trade. I am the CMO of Tampa Family Health Centers and have been here just almost 11 years now. Time goes fast in the community health world, and I consider myself a lifer. I am extremely passionate about the population that we treat, and when an opportunity arises where an economic opportunity meets a clinical opportunity, they mesh together, and it's great for both the health center and the patients, that's a good day in my mind. So when infusion medicine was brought to the table, there were so many questions. A lot of those questions, for myself, how is this possible? I love taking on a new journey. And so I'm going to try to answer some of those today and just kind of go through how we got here where we are today when we opened our infusion center of September of 2024 and answer any of your questions from there. So just a little bit about us at Tampa Family. We are 14 healthcare centers in Hillsborough County in Tampa, Florida. Just like many of you here from your CHCs, we have all the primary care services, and I do have 13 in-house pharmacies. We provide dental, food pantry, all those wraparound services for our patient. As Dr. Anderson stated before, community health centers, when we don't have the programs or the services there to refer our patients to, we create them out of need. So all the services that we have, we've created out of that need, and happy to share that in 2024, we served over 113,000 individual patients for almost 383,000 visits. With that said, I will get to why you came here today, and what you really want to talk to me about is why Infusion and why now. Climate is changing out there. Primary care, CHCs do very well. We're the largest primary care network in the United States. But there's come the time with risk-based contracting and financial grant funding, things that we're not sure about anymore. We have to start making those decisions on how do we diversify? How do we bring some of those things in-house? And so that's why we landed on infusion medicine. Marry that to the research that we did around our patients who may have a chronic condition, may have no med prescribed or med prescribed to them that they never picked up, or an infusion recommended that they never got. So we did a little bit of that research and partnered with Junction Health, who similarly showed us the map that Dr. Anderson showed to you for the Boston area, but in the Tampa area. I was absolutely astounded by the lack of infusion centers for patients who are on Medicaid. And as Dr. Anderson said before, if you want uninsured, forget about it. Well, challenge accepted. That's what we do best. And so we went to the drawing board and said, how can we make this happen? How can I push this forward? And that is where we teamed up with Junction Health. It's important to know what you do well and what you need assistance with. And so I was very, very happy to partner with Junction Health to talk about how can I bring these medications to vulnerable populations, and then how does it benefit the health center? Because God forbid you don't want to do it wrong. And we've done it absolutely right. Third part to that for us was, and we'll talk about this more a little bit later, was how do we get primary care providers comfortable with ordering infusion therapy for some of the basic chronic diseases that are out there. And then in stepped ConferMED with that. And this trifecta of partnership has been amazing for us here at Tampa Family. I know we're not the first FQHC to do it, but we are one of the FQHCs doing it, and we are doing it very well. So I'm very, very proud to share our story here today. And with that, I'll pass it over to Vinny to just tell you a little bit more about our partnership with Junction Health.
Great. Thank you so much, Dr. McPhee. So this kind of on our side started about 3-4 years ago in conversations with a thought partner who was a CEO of a federally qualified health center. His name is Ben. I think he's a participant here today. And we were just talking about, well, how do we better utilize 340B within federally qualified health centers? And infusion came up. And I was very familiar with it, having been with health systems that had been doing infusion in 340B for many, many years. Almost all of my career is in nonprofit, right? So I saw the effect that you can have on patients and the positive effects that you can have in access to care. And utilizing 340B. Unfortunately for the patients in the hospital, they were getting some pretty high out-of-pocket costs. So it wasn't a great situation for the patients, but it was great for the hospital. So we thought, wow, this would be great for an FQHC and for patients. It's a win-win. And so intuitively, we knew that there was this access gap because hospitals do take Medicaid patients for infusion, and they can take uninsured patients. They're certainly not jumping out of their seats to do so for either. And so intuitively, we knew that there was a problem. And so we mapped it out. So that Boston example, the Tampa example that Dr. McPhee referenced, you can actually go on the National Infusion Center Association locator. It's the same story for any community in America. There's infusion deserts everywhere for those that are underserved. And so then we actually went out and got some actuarial data to say, well, how many patients would we expect in an attributed patient population? So for Tampa Family, it was, hey, you have 113,000 patients. Based on the aggregated data in the market, we would expect that X number of them need X number of infusions per year. And you could even dial it down to condition and drug. And then we developed a key set of hypotheses. The first and the primary one was, are we going to be able to address a care gap in communities? And actually, are there volumes of patients that are out there that are going without care today that just need somewhere to address their care? And can it be financially feasible? And so we'll kind of walk through that. Now, then you had to really understand the health center organizational structure in order to make sure that this is set up appropriately. Many health centers could set up an infusion center tomorrow. The biggest issue there is if you've got PPS contracts for federal and state beneficiaries, that's a great thing for primary care. Let's say you get $160 for a primary care visit for a Medicaid managed care beneficiary. That's awesome. That's a great payment for a primary care visit. But let's say that patient is getting 10 vials of Remicade every 8 weeks. You could be losing a lot of money because you're still getting $160 for every single infusion. So that was a problem that we needed to solve for first and foremost. And the second, Ben highlighted right away. He's like, hey, anytime I've ever had an idea or people around me have had an idea at the health center, it all sounds great. And then everybody kicks me under the table and they said, well, who's going to do it? We are stretched thin. I mean, we've got a crew that's dedicated to the mission, but we don't have a ton of bandwidth. So we wanted to try to solve for that. And then revenue cycle. These drugs can be very, very expensive. And the more expensive the bill, the more the insurance company wants to deny it. And so you have to be really buttoned up there. And actually, the worst thing that could happen is that they pay you at a rate that you think that you're supposed to earn. And then after the fact, they come back and they say, well, wait a second, this is an in-scope service and this is a PPS contract patient. You should have only gotten $160. So we're going to claw back payments from the last X amount of months or years. So we wanted to avoid that. So we put together a wide set of expertise in this space, sort of amalgamated it into a big comprehensive package, and then all the busy work, policies and procedures, tons of legal and regulatory, workflows, tech stack, you name it, all sort of put together. And then we were introduced to Tampa Family Health Centers, who they were at the apex of, yes, we want to do this. Yes, it's complex. And yes, we would like a partner to help us set it up. And so our model is they own it and we help them get it set up and operate it with the aim of getting this thing up and going as efficiently as possible and integrating with existing provider workflows. They use Epic, but one Epic isn't every Epic. Everybody has a slightly different Epic instance, and some are on ECW or Athena. I mean, there's health centers on all kinds of different medical record systems. And so how would we integrate this as effectively into Tampa Family's provider workflow as possible, such that it was easy for providers to refer patients over to infusions? It's one thing to set it up, but it's another thing to actually get infusion referrals, and we wanted to make that as easy as possible. So the goal is to provide a new revenue source, a sustainable revenue source, so that we can take care of patients where there are gaps in care. These are the sort of key specialties that we wanted to address. But it is a revenue source as well. We're doing the right thing for patients while also providing a new source of funding for the health center. But we still had this issue. How do we surround these PCPs? And Dr. McPhee referred to this earlier. Like, they need to have the resources to be able to do this, to be able to take care of these patients. And not every health center has all these specialties, right? And so, Dr. Jackson's going to really kind of close the loop there on how we got with ConferMED to make that work. So what's the effect? We've been open for just about 6 months now. We've put underutilized space to way better use. This is actually one of the infusion rooms. I call it the presidential suite because family members can come and visit with patients as well. And the big thing here is Tampa Family Health Centers is able to provide more comprehensive services because they have things like infusion. They've got obviously pharmacy that are sort of the endpoint of what specialists are recommending. And through that partnership with ConferMED, they're able to extend the breadth of their care to include a heck of a lot of specialties. And when that ends up with an infusion, we're there to take care of those patients. They don't need to go elsewhere. For a Medicare patient, they don't say, well, you can take care of me for all these things, but you can't take care of me for this other thing. So I'm going to go over to the hospital, and then you lose them forever. So average 340B savings on our infusion drugs is a little north of 40%. And the average gross margin on a Medicaid managed care patient is about 30%. So we do well with these patients. And those are patients that doctors' offices lose money on. So they actually are some of our best referral sources if they're infusing patients. So I'm going to hand it over to Dr. Jackson to talk about how they brought specialists into the mix here.
Thank you for that. So we had a number of core didactic sessions amongst the different subspecialties. I participated in one of the core didactic sessions. And the purpose of the core didactic session was to provide information, provide the knowledge base, provide the infrastructure to have a base on where to go from when you see patients who may be candidates for infusion. And that's important because this is something that you may not be as familiar with. And we want to be able to essentially build that bridge. So, and also give the information that is necessary, because that's one of the big things, especially when it comes with inflammatory bowel disease in gastroenterology, is that you want to make sure that not only do you know about the disease process itself, but you know what information that you need to have. And then once you have the information present, then you can make a decision on what type of infusion you want to go ahead with. And that's kind of the step-by-step process that we want to utilize in order to be successful, because just like it was said earlier, these are very expensive drugs, and they're not benign. There are side effects, there are issues, and so we want to make sure that we have success, and ultimately, especially when it comes to, I can speak for GI, we want to be able to achieve remission. So and that requires a fair amount of information and some knowledge base that we can work back and forth with, at least through the eConsult platform, in order to achieve. Next slide. So this is a case that I was involved with. So this is a 24-year-old patient. They've been off Crohn's medication for about 6 to 12 months. This particular patient has been unable to get into see a gastroenterologist due to the issue of secondary insurance. Now there seems to be a recrudescence of their disease process. So they're now struggling with abdominal pain and hematochezia, gas, diarrhea, and they want to start back on infusions. He was previously on inebilizumab or Humira for 17 years, but then was transitioned to Skyrizi after Humira was not effective. And then he was supposed to start Stelara, but was unable to do it insurance and wouldn't be a candidate for Remicade. So labs, clinical notes were attached. And so this is an example of where we have information, in the sense of we have information now to say that the patient's now has lost control. Now the disease is active. And there were labs and clinical notes attached. When it comes, like specifically when it comes to gastroenterology, when it comes to inflammatory bowel disease, there needs to be a little bit more of a cadre of information where were there previous CAT scans, has the patient undergone previous surgeries, does it, and what did the endoscopies, what did they show? And there may be some other attributable labs that we need to get as well. So that's the kind of information that we need to get. And that's the kind of information we need to have in order to give you and be able to direct you in terms of, okay, what type of, what it really starts with is, does the patient need an infusion? Most likely, yes. Okay, if we're going to do the infusion, what type of information do we need? And then we can make a decision on the type of infusion. And afterwards, then it comes down to how frequent do we want to give the infusion, and then move on from there. So those are so this is just an example, a real world example of what we deal with in terms of how we manage what type of information, how we go about starting infusion therapy. Next slide.
Great, Dr. Jackson, thank you so much. So we are going to jump straight to, we have a poll question. And so I'm hoping that all of you in front of your computer, where you'll see on the screen a question, if you could click on your answer, take a look to consider that, and we'll play the Jeopardy music in the background. And we have one additional poll question that we will post a little bit later. And once we see your responses, we'll give you about a minute to answer these, and then we will jump right into questions. And I do, while we're waiting for you all to complete and to answer the question, remind everybody that there is in the center of your screen at the bottom a little button that says Q&A. If you click on Q&A, you can post any questions that you might have. We're not going to be doing live questions, so please, I already see some of them coming in. I'll be moderating those questions, and we'll do our best to get to as many of them as possible. And I already see we've got some great questions that are going to be, we'll get to as soon as we can. So just take a second. Do you currently offer some form of infusion medicine service to your patients? Yes or no, or unsure? And if you responded no or unsure, are you considering offering infusion medicines to your patients? And I suspect the answer for this question too maybe depends what you all tell me about about how this works. And we will be fleshing out the answer to that question in just a few minutes. So Megan, do we have results? Okay, so 12 out of 61 respondents said they are offering some form of infusion. 46 out of 61 said no. And for those that said no or uninsured, considering it, 60% of you, and 3% no. Okay, great. So just gives us a sense for sort of who's on the webinar today, and what your perspectives might be, and what sorts of questions you may have. So let's jump right into it. So Vinny, I'm going to ask you the first question. I'm pretty certain that many of the health centers will find the prospect of setting up and operating an infusion center to be quite daunting. And I know in conversations that you and I have had, and that we've had with Dr. McPhee, the decision to do so is not to be taken lightly. This isn't a simple prospect. What are some of the challenges for a health center if they think they want to go down this road? And what approaches have you seen that help health centers do it successfully?
Yeah. So first and foremost, what I'm actually going to try to do is answer the question while also answering some of the Q&A questions that are embedded here, so that we can kind of kill two birds with one stone.
Yep.
First and foremost, you have to address the payment issue. There's a couple of different ways to do this. You can do it in scope. If you do it in scope, you'll have to figure out a way to bill for the drug separately. And most infusion centers within a health center that go this route utilize their pharmacy to actually purchase and bill for the medicines, and then they bill for the chair time over in the clinic. It does have its limitations if you do it that way. A lot of drug companies will restrict access to certain drugs unless you have certain accreditation, URAC, ACHC, or both for specialty accreditation. And some payers basically say, well, if you're trying to run this drug through the pharmacy, well, you've got to use my pharmacy. So we end up needing to refer those patient prescriptions over to like an Optum or an Express Scripts, which is a Credo, or some other specialty pharmacy that's owned by the payer. So that's sort of the downside with that. But the upside is you don't need additional gap coverage. It's covered under FTCA. And you don't need to jump through any additional hoops for 340B compliance. If you do it out of scope, you can actually get whole new contracts, carve out the drugs, pay for them, get them paid for separately. But then, well, it's not covered under FTCA, although we have found that it's not nearly as expensive as folks think it is to get gap malpractice insurance coverage for an out-of-scope service. And I would encourage you to actually inquire locally because most are surprised at how cheap it is. And then, and sort of the other piece there is, well, then you have to create a mechanism to ensure that a patient is 340B qualified before they're referred over to infusion. So I'd say the structure is probably the most difficult, figuring that out and working with legal. And then the next step is just the bandwidth. There's a lot of things that you have to do to even get started. It's not just like, well, we'll just build it and it'll work. It can be tremendously difficult. You have to have a lot of expertise in a lot of different areas. And if you don't have, at the very least, proximity to specialists, ConferMED is a perfect example of having proximity to specialists. But if you don't have something like that or a specialist in-house, it can be difficult to drum up referrals that are financially viable. There's a lot of patients that are attributed to your health center that are today need infusions, but a lot of those are low value. In fact, if you take your total number of adult patients and multiply it by 0.013, that's the number of infusions that you would expect to get for iron and hydration that are low value infusions. You're going to get those, and there's a need. But you need to also support some higher value infusions to make it financially viable. So hopefully I've answered a couple of questions in there while answering your question, Dr. Anderson.
Super, thanks, Vinny. I'm going to pivot over to Dr. McPhee. Dr. McPhee, I've been in your shoes. I was a medical director for many years as well, and I have a pretty strong hunch that if I had gone to my medical providers like you did and said, "Hey guys, we want to start an infusion center," that there would have been a variety of responses, and maybe not all of them, 2 thumbs up and I'm all in. But tell me a little bit about when you did start socializing this with your providers who were going to be the prescribers and managing this. What was their reaction, and how did you get them on board?
Well, Dr. Anderson, they didn't talk about me to my face, so they may have said a couple of things behind my back, but to my face, mouths dropped and eyes widened when I mentioned bringing infusion. There was the, how are we going to do this? We have cultivated a really great culture with our providers, a lot of buy-in from them at Tampa Family. We've done that by having bi-weekly meetings where we're talking through workflows and going through things together. So they're used to going on a journey with me when I have a new harebrained idea of what we can do at the health center. But yes, there were very valid questions on, I have a lot of APPs, more than physicians that I have. I think that's the nature of CHCs throughout the United States. And a lot of them hadn't trained at a space where they had been in infusion or given an infusion or had to decide, whether infusion should be given. And so we leaned in on the partnerships that we did have to say, how can we educate you? How can we make your clinical acumen stronger for these things? And that's what we did with ConferMED. We said, hey, we already use this e-consult platform and you're getting these wonderful consult notes. So kudos to that, back with so much education that's in the notes from our specialists. So thank you to Dr. Jackson for that. There's so much education for the providers inside of the consult notes. And could we use that as well for infusion and help them in deciding when to order, when to refer. Of course, I got questions on who's doing the prior auth for this, who's going to be doing the paperwork. Can I refer in anybody? Do they have to be commercially insured? Do they have to be Medicaid? Can they be uninsured? There was so many questions that we had to kind of weave through for the providers in laying down the foundation for that. We started early. I would say definitely start early with your providers if you know that this is something that you want to do, with the introduction of the idea and having those educational sessions with the specialists at ConferMED to start laying Infusion 101. Let me talk to you about GI. Let me talk to you about neurology. Let's do dermatology, and seeing in what instances you may want to order an infusion. And I do think that helped. In our off calls from those lectures and talking with the providers, they were really excited that we did that. They felt that it was very helpful to them when they were going to go through the workflow of ordering the infusion. I hope that answered your question.
Sure. Excellent, thanks. So I'm going to turn to Dr. Jackson next. So, Dr. Jackson, that initial example I gave of Project Echo and hepatitis C, I remember when I was working in that space and starting up Project Echoes and helping primary care providers. Often when I would talk to GI providers about this, they said, that's nuts. Hepatitis C is for GI docs. Primary care providers shouldn't be getting into that. And I said, well, we have this thing called Project Echo, and it actually really works really well. And look at the New England Journal. But I'm curious now, to what extent the analogy extends to what we're doing now. You treat Crohn's disease, ulcerative colitis on a regular basis. You're familiar with these drugs, and now you are supporting frontline primary care providers who may be starting their day seeing somebody with a migraine headache or seeing somebody for well care, and now they've got a Crohn's disease patient and they're reaching out to you. How does that work? What's the interaction like, and what have you learned in the best way to support these PCPs to take this challenging new topic on?
So there's reality versus ideology. And so sometimes as a subspecialist, we don't really manage that as well as we should. And so that's what we're trying to break here. So I think hopefully this answers your question. So what I've seen is, I mean, what the first thing I've seen is with the e-consults is that I'm impressed by what I'm seeing, because I'm seeing that there's the effort to understand the disease process itself, and to understand what's going on and understand how to manage it. And so, and there's a problem here, and what do we do? I think one of the big things is, and I think Dr. McPhee touched on this, is the education. And so what I'm trying to do is, as a subspecialist, is try to not only just say, just instead of just saying just as a checklist of do, these are the reasons why. If the goal is that, yes, we need to get to an infusion, that's the goal. And so now, in order to get to that point, this is the information, and this is why I need the information, because in order to get there, this is what we need. Because the patient wants to get there, you want to get there, I want to help you get there. And so that's what it takes. It can be, and yes, as I will say this, as a subspecialist, we can be somewhat obsessive and somewhat compulsive. However, it's it's meant to be in a benevolent way. And so that's important, because what we don't want to do is, A, we don't want to get the wrong infusion. B, we want to make sure that when we do give the infusion, that the patient's going to be able to achieve remission. So that's what we're looking at. And so that's the information that we're looking for. I don't know if that exactly answers your question, but if not, please, I can keep going.
Yeah, absolutely. And I want to clarify, just so that everybody knows, Dr. Jackson is the GI infusion reviewer for Dr. McPhee and all of her staff, and he is speaking to you and practicing in Southern California, whereas Dr. McPhee and her entire team are in Tampa. So this is a 100% virtual engagement. Those lectures and webinars are given, obviously, virtually, just like we're doing today, and the e-consults occur across time zones and geographic distance. And I think for us, that's been one of the keys, is that there's no way we're going to find an infusion specialist in Tampa for every one of the specialties that you need. And so Dr. Jackson's in California. I think our hematologist is as well. They come from all over the country, and selected specialists who want to do this work and have the expertise, and I think the vision that Dr. Jackson laid out. So we have a lot of questions, and I want to get to them, but I think, Megan, we have one last polling question that we're going to put up, and I will start teeing up the questions. Okay, so if you're considering offering infusion service, what potential barriers most concern you? Choose up to 3. We'll give that a second for you to answer that, and we'll show the results. And Vinny, I think, are you answering some of the questions in the chat while we're going? Because I see some of them have disappeared, so I think you answered them already. That's great.
And trying to, they move over to the answered tab if you wonder where they went.
Yep, I see that. Okay, I'm actually going to read some of the ones that you've answered once we show up our poll, just so that others in the group can also hear those responses. But just give you a second more, everybody, to answer your question, and then we'll pop up the results and see what your concerns are. All right, so lack of operational expertise and financials are in the lead. Uncertain patient demand, absolutely. Lack of clinician buy-in, definitely understand that. Limited 340B expertise and space constraints, great. So yeah, a wide range. And I think as we dive into the questions, we will likely be able to address maybe not all of these, but many of them. So let me get right to the questions. And so Vinny, would you mind speaking to the group, the answer to the initial question, does infusion therapy fall into HRSA approved services and FTCA coverage? I think you sort of covered that in your question. Let's just knock that one off, because that's fundamentals that we want to get covered right away.
Yeah, if like I said, in general, there's a couple of different ways to set up infusion. If you're doing it in scope, then FTCA applies. If you're doing it out of scope, it doesn't apply, and you need to get some sort of gap insurance out in the market.
Okay, great. So can you talk a little bit? I think this question will also be Vinny to you as well. So a lot of people have asked about the numbers. do I have enough patients? So I saw one of our questioners said, we have 60,000 patients in our practice. How do you, and I know in conversations that you and I have had before, you have said that the infusions that you ultimately will provide are not necessarily coming 100% from your patient population. You may be drawing people in because there's Medicaid patients being cared for by somebody else who also can't get the infusions. Can you talk a little bit about the math and how a health center would think about the numbers? And am I big enough? Do I have a large enough catchment area to potentially generate the number of infusions that I need in order to be able to make this work financially?
Yeah, and I've tried to answer this in the questions that I've typed answers to, but the most correlated factor to making this financially viable is proximity to specialists. If you either have PCPs that are really on board with something like a ConferMED type service where they're really, really comfortable interfacing with specialists that they don't have on board, and supporting their patients, as opposed to referring them out and not knowing what kind of care that patient gets. That's very helpful. If you have in-house specialists, obviously you've got an in-house referral stream already there. That is by far the number one correlation to making this financially feasible. The more patients that you have, the more infusions that people need today. A lot of those are a little bit north of break even. They're not financially super viable. It's mostly iron and hydration. You've got actually a ton of patients that need iron. IV iron is so underutilized, and we realized very quickly it was like 90% of what we were infusing, and short enough, it was 6 to 7 patients a day needing IV iron, tons and tons of OB patients especially. So it's a huge problem for this patient population. So you need to really kind of start there. And I've in the Q&A, I've typed out what that calculus is to know how many of those sort of embedded infusions that you have. And then the rest is really, really based on the proximity to specialists. What we also do is we go out in the community and we reach out to specialists and we talk to them very, very actively about like, hey, not only do we offer this service, but we take care of patients regardless of, what their payer source is. And I mean, that includes uninsured patients. We get referrals for uninsured patients. And those are the patients that we take care of one time. And then we work with Tampa Families Financial Counselors, and we set those patients up for an ACA, Affordable Care Act marketplace plan. And suddenly they're insured and they become commercial patients. And we get them on copay assistance. They still have no out-of-pocket costs. It's a win-win for everybody. And then the referring doc is like, oh, you take care of these patients that are in most need. That's even better. You get even more referrals. So by doing good, you can do good.
Dr. McPhee, so based on what Vinny just said, this means not only are you offering infusions to the patients that are currently on your panel, but you're bringing patients potentially from the outside. From what I understand and everything that you all have shared, those patients now need to become a part of Tampa Family Health. They need to be on your panel. They need to count towards UDS and all of the other factors. How do you manage that process when you get people from the outside and kind of assume their care and are responsible for the quality metrics and all of those other things?
Yeah, absolutely. So we were lucky in that we utilized the space that we already had, that we were underutilizing at the time for the services that were provided. So we were able to flip it to our infusion center. We are able to have our primary care located right in close proximity to the infusion center, along with the 14 additional health centers that we do have here. So it's easy for us to be able to do that intake. And I think it also stems from the great partnership that we have with Junction Health as well. So the workflow and our nurse practitioner that sits a part of the Junction Health team communicates very well with the Tampa Family team. For all intents and purposes, she walks, talks, and is Tampa Family. No one would know the difference if you walked into our health center. And so she is able to make sure the patient gets that intake visit done. Everything is on the up and up before we get them in for their first infusion. And Vinny alluded to this before, but the amount of administrative work that goes into making sure a patient has a payer source helping them apply, working with our people, getting prior authorizations through. Junction Health takes on that for the health center so that our bandwidth isn't stretched any more than it already is. And that has helped tremendously in this workflow. And then there was one more thing that I saw in the chat as far as spacing for this. We're not compounding any medications here. We're not a compounding pharmacy, but it doesn't take a whole lot of space. It's one of our smallest spaces actually that we have, but we made it look very nice and it feels good. And to have an individual patient room in which you can get critical treatments that you need in an FQHC setting. I mean, the patients have been blown away and our partners have been blown away when they come take a look at the infusion center, but it doesn't require a whole lot of space to do this.
So, Dr. Jackson, I've seen, I think I've read all of your GI consults that you have provided to the Tampa providers, all of them contemplating some form of infusion treatment for ulcerative colitis or Crohn's disease. One thing that I've noticed is that often, and I don't mean this in any way with disrespect to the PCPs, but often they don't come with all the information that you need. And you mentioned you specialist guys can be a little bit OCD and have a lot of things that you need. But so talk a little bit about how you work PCPs through that. I don't think I would necessarily know that I need this test and that and all the things that I've seen you ask for. So how do you manage that scenario and what's the result?
Sure. So lots of ways, lots of things that I've done over the years. So we have a number. We have four or five nurse practitioners that work under us in GI and liver. And when it comes down to certain areas like this, we first start off with didactic sessions. We also have sit down sessions where we actually interact with them, where they actually bring a patient case, and we actually sit down and educate, so they understand where we're coming from, and in order to get them to a level of independence. And we work with them. I actually worked with one of my nurse practitioners yesterday with a very difficult infusion case. And so because it's one of those things where it's almost like a back and forth where you have to, it's not just static and it's not just one thing where, okay, do this. There needs to be a little bit of a back and forth. And so we do didactic. I've done that also with primary care physicians. We've done didactic sessions, but we've also done one-on-one sessions. It's almost like an in-house kind of echo, but we've also done the echo as well, but also we've sat down and be able to, it's like, okay, here's a case, here's an actual case, and then we go through it. We've also worked with the e-consult realm, where we go back and forth on e-consults. That's not a problem either, where hopefully I always like to say, and if I'm not saying enough, I'll be more cognizant of it. Please reconsult me, please question me again if you have more questions, because I don't want it to be something where, okay, this is what I told you to do or asked you to do, and then that it just ends there and I'm gone and I'm doing something else. No, this has to be an ongoing, continuous dialogue in order for this to be successful, and that's crucial. Whatever type, there's multiple infusions we give in GI, but that's crucial with this. So there's different ways to do this. I think, like, for example, the didactic is good. I've given multiple didactic sessions to nurse practitioner and primary care physician, which is great because that gives you a great overview. But then there's the actual, like, either e-consult or I like to do the more personal sit down. Let's talk through the case. Let's go through the case. Let's have a discussion about it so we can really, one of my professors back in college says the only way you're going to understand a book is to gut it. You got to gut the book. And so that's the same thing here. You got to really open up this case and find out what's going on. And so we can help become independent. So those are the ways that I've gone about it to help lower the anxiety and then raise the independence.
Thank you for that. Vinny, I know in conversations that we've had, I've heard you speak of, I don't want to say good states and bad states, but there are, I think from your experience, some states where this works really well and some states where the value proposition and the ROI is a little bit more questionable. What are the characteristics that would make a program like this more viable or maybe less viable?
Sure. The short answer is states where Medicaid managed care organizations will pay you at whatever a normal contracted rate is, and the state is not expecting to take the 340B savings away from you on Medicare or Medicaid MCO claims.
Mhm.
Every single state, Medicare, Medicaid fee for service takes your 340B discount, and you're only making 15 to 20 bucks per infusion. So those ones are slightly lower than break even. But in states where, like Florida, where the managed care organizations, they'll contract, based on Medicare rates. So, an MCO may say, oh, we're going to pay you 90% of Medicare rates. And for most doctors' offices, they look at that and they're like, man, I can't even break even on that because, Medicare rates barely cover my costs. And so for doctors' offices, that's bad. But for us, it's perfectly fine if you're buying the drug at 40% off the cover price. And so that's the biggest factor in like just kind of back of the napkin. Does this work effectively? The second biggest factor, again, I'll go back to the proximity to specialists. If you've got enough specialists that are writing for these products or suggesting these products, and you have enough commercial and Medicare patients, it could be very viable. So it just totally depends.
Yeah, I was surprised when I first learned about this program that it was being implemented in Florida. No offense to Florida, but it's a non-expansion state. And I think, Ashley, if I recall, you've got about 30% uninsured. And I think you touched on this a little bit before, but you've been able to make this work even with uninsured patients to some extent.
Yes, we're down to 20% uninsured
Okay.
with a targeted
Hip, hip.
effort with the front desk and the financial counselors to attach our patients to payer sources here. We're in a unique position.
Yeah.
We have something called the Hillsborough County Healthcare Plan. That is a county insurance plan of sorts that our residents can get on. So that puts us at a little bit of advantage from that standpoint to help with that. But yeah, we have been able to connect our patients. As Vinny said, there are copay assistance, patient assistance programs. They have had 100% success in connecting our patients and getting them covered with payment assistance. And then after they have that, the workflow is to connect with one of our financial counselors so that they can get connected to some sort of payer source if eligible. I will say that we do, as Vinny said, too, have a high amount of iron infusions that come through, and those don't win you a lot, but it's necessary and it is needed, and it is something that at least, even if they're dropping to the sliding scale now and paying a cash price for the infusion, that you're getting something on and you're able to collect on, whether that's chair time, administration type things, and we can push those patients through. And that's mostly a lot of women's health patients, probably some GI in there too, Dr. Jackson.
Yeah, so I want to clarify one thing because I see in a couple of questions, the nature of Dr. Jackson's role may not be entirely clear. Dr. Jackson is actually in Southern California, as I mentioned, but Dr. Jackson is providing peer-to-peer consults, not actually prescribing, not working in a health center. Dr. Jackson, I think you work in a GI clinic, if I understand your setting correctly. So that brings me to a question back to Dr. McPhee or maybe to Vinny. Who is prescribing the medicines? And who is administering the medicines? Let's talk through the actual process a little bit. So Dr. Jackson sends his recommendations for that last Crohn's disease case. I think Remicades the right thing. Here's what I would suggest in terms of dosing, but do these tests first. Back to you, Dr. McPhee. Now what happens?
Back to me. I say, yay, great, read through it. I complete the referral to TFHC Infusion Center. We have the referral set up by specialty. So I would get to pull out my handy dandy GI referral, get that filled out, send it over to Vinny and team, not Vinny directly. We do have a team. We have a nurse practitioner over at TFHC Infusion Center. We transmit that referral through. Now we do use Epic, and the nurse practitioner can see into our system too as well, just as Dr. Jackson can. So he can see essentially into our Epic as well for the peer-to-peer communication. Then I take that referral and I get it over to TFHC Infusion Center, whereby Vinny.
Yeah. We take it. We first go to the insurance and say, all right, what are the prior authorization requirements? Is there a different preferred product? Is there a biosimilar that's preferred by the insurance? That's the nice thing about having an NP, or you could use a PA or a mid-level, or I guess you could spend money on an MD or a DO. But you can have that provider basically reach out to, Dr. McPhee and say, hey, like the insurance preferred is a different product. Would you like me to just go ahead and switch that on your behalf? And, you know,
Mhm.
they can do things on the fly as well as order pre-meds or, in the event of an emergency, we've got a protocol by which any RN could follow. That's been approved by a medical director. But if you need to make any deviations to that, it's nice to have a provider on site that can actually do that in real time as well. So that's sort of the general flow.
Great. So what's the staffing? I know one of our attendees asked that question, and let's share that with the entire group. So in your current infusion center, Tampa Family, how many staff do you have and who are they?
Started with one nurse practitioner, right?
Yeah.
And
Started from the bottom, now we're here.
yeah, 5 infusions the first month, one nurse
Yeah.
practitioner.
Yeah.
More twiddling of thumbs than one would have hoped. This is our 5th month,
Yeah.
and we are on track for 130 infusions this month.
Yep.
Um, Actually, just this morning, got an offer letter back from an MA. We're adding an MA. So our NP provider is very comfortable with anywhere between 7, 8, 9 infusions. It depends on the complexity of the infusions in a given day. Adding an MA, we feel we'll be able to increase that by 4 to 5 infusions. And an additional RN can add you another 7, 8, 9 infusions as well. Again, depends on the complexity. Some are 6-hour infusions that are really complex, and some are 15-minute injections with monitoring. So that's kind of the general guidelines.
And follow-up question to that, what kind of conditions are you mostly treating? You mentioned iron, but other than iron, what are some of the other big conditions and meds that either you are starting to see or you're hoping to see in the near future? What are the big three?
Yeah. Crohn's and ulcerative colitis is definitely a big emerging one. We've got a lot of osteoporosis patients as well. There's some injectables for osteoporosis that a lot of PCPs are comfortable with, and we also get them from outside rheumatologists. We've got some patients that require migraine meds. That's another one of them. There are all kinds of different emerging therapies in different areas. We've got MS patients. We had a patient who had just delivered a baby, and she had a 5-month-old and couldn't hold her baby because her MS was out of control. And she'd been rejected by 2 other infusion centers. And they get to us, and we don't dump patients. We let patients know. I'm glad that you found us because you're going to be taken care of.
Wonderful. Well, we are coming to the end of our session, and I want to encourage everybody to complete the evaluation that you see on your screen now. Please let us know what you thought of this. I want to add my additional thanks to Vinny, Christian, and Ashley, not just for your technical expertise, which you obviously have in abundance and brought and shared with us, but also for your passion. I think what I've learned in the years that I've been in the health center movement is a lot of people with great technical expertise, but it's the passion for our mission, the passion for taking care of our patients that actually makes the difference. And it's why people who go to an FQHC love their primary care practice, love their primary care provider, even if they have a general mistrust of the larger healthcare system. And that was obvious in your responses and in the way you described the work that you're doing. And so I want to personally thank you for that. And thank everybody, the Weitzman Institute, who helped us to coordinate this and deliver it. We will be sending the recording, a link to the recording probably tomorrow. You'll get a follow-up email from us so that you can review the greatest hits or share it with your family or whoever you would like. And we'll also give you an option if you'd like to follow up and learn more on a one-on-one basis. We're happy to meet with you as well. So on that end, I want to thank everybody who attended, thank our participants, and wish everyone a great rest of your day. Thank you so much.